Couple of them are 14, 18, but not neonatal there, not at that age. 14, 18, we had couple of patients. Majority of patients are about 30 years of age. Now the other MODYs, MODY 1, MODY 3 and MODY 12, they are all usually below 25 years of age. They are about 20. So if they get slightly older age group, then we should suspect that it is this particular type.
Yes, we got the...
I have a question too.
Yes.
Am I audible?
Yes, yes.
Sumi,
Pushpa.
I'm with a friend.
Oh, the print. Sumi.
Okay.
Okay, yes, Sumi. Yeah.
Yes.
Yeah.
So I understand that you mentioned that we don't have an estimate of how many people would actually be having this type of diabetes.
Nor do we know, Sumi, for any of the MODYs or anything. They're only guesstimates.
Yeah. So of all the diabetes that we have, do we have an estimate of at least how many types can be categorized as MODY? Also, since you said that now that diabetes is also going in the realm of precision medicine. Precision medicine is something that is only for MODY type of diabetes, it's not for type 2 and type 1 diabetes. Can you please elaborate a little bit on that?
Thank you for both the questions.
Sir, this is Anuradha here.
Anuradha, one second, let me answer Sumi. Otherwise I'll forget Sumi's question. After that, Anuradha. Sumi, the MODY, overall prevalence of MODY is 2%. So if you have 100 patients, 90 will be type 2, but many of those type 2s may actually be wrongly diagnosed. They may be actually MODY, but from what we know, roughly about 90% is type 2, about 2 to 3% will be type 1, 2% will be MODY, maybe another 1 or 2% will be gestational diabetes, and then another 1 or 2% will be all the other types put together. So it's not very common. Among the MODYs, MODY 3 is the commonest media. We just finished one more study which we are just submitting for publication tomorrow, I think, where we looked at pan-India MODY and we looked at 65 collaborators sent us blood samples from all over the country. So we looked at, but we didn't do it to this level of thing we didn't do. We just did the genetic testing. MODY 3 is the commonest, MODY 1 is the next, and 1 or 2 MODY 12 also we picked up in that. So we'll have to now do a more detailed analysis. When you find MODY 12, we'll have to start looking at this gain of function or loss of function, which we have not done routinely. Now it has opened our eyes. We will start looking at, once we tell people that such a thing is there, more people will start referring, and even in the world, more people will start picking up. The second question was about precision diabetes, whether only in MODY it is there. MODY and neonatal diabetes are what we call as the poster child of precision diabetes, because your treatment completely changes once you find out. But within type 2 diabetes, 2-3 years ago, Dr. Anjana and our group from MDRF, they described 4 types of type 2 diabetes. A lean type called severe insulin deficient diabetes, SIDD. Then there was an insulin resistant obese type, IROD, insulin resistant obese diabetes. Then there's a combined one, both deficient and obese. And then there's a mild age-related one. At 60, 70, you get mild. So type 2 diabetes is of 4 types now. Okay. Type 1 diabetes is also of 2 types, where you can get one where antibodies are positive, one is antibody negative. So the field is, even within GDM itself, not all GDM is the same. So I think precision medicine is getting more and more into more scientific terms. But monogenic diabetes, like neonatal diabetes, MODY is the classic case where without genetics you cannot even treat. You have to do genetics. Type 2 somehow you can treat with some thing, and with type 1 anyway you are going to give insulin. But here, the entire treatment will change. If neonatal diabetes, you go and give insulin to that child, unnecessarily the child will take insulin, sugar will never get under control. If you stop the insulin, child will get the beautiful control. Yes, Anuradha, now go on.
Yeah, sir, I understand specifically to the 20 cases.
Yeah.
Of course, the genetic test was done, but some of the symptoms, if you could help explain, and also because this is a new area, people are going to be very confused. Like, I have diabetes, low sugar. How does this, take it forward? I mean, in the sense, better, wider. Yeah,
thank you, Anuradha. Symptoms of diabetes are the same: thirst, urination, loss of weight, losing weight, all the wounds which don't heal. Symptoms are the same, whether it's type 1, type 2, MODY, those symptoms don't change. Low sugar doesn't come at all, because these people didn't come to us for low sugar, they came to us for diabetes. Now remember, some of them are picked up in our center. Some were referred by other patients, other doctors. They were treating and they said, this doesn't look like type 2. These are thin people. Why are they getting diabetes at 25, 30 years? Doesn't look like type 1. They have stopped insulin, nothing happened to them. Could this be MODY? Could be something. Then they refer to us. Okay, Chennai, they will find it out for us. So they send the blood sample to us. Every week we get blood samples from all over the country, especially for neonatal diabetes, but also for MODY. Because we have been an ICMR center for a long time, and since we've been publishing a lot in this, earlier all the blood samples used to go to UK. Only in England they were doing, Exeter. There was no lab in India. Since we set up the lab after other joined 25 years ago, slowly we've been setting it up. Last 10 years, we've been doing for anybody, any medical college, from Institute of Child Health.
Samples. We've done about 2,300 samples have been referred to us. No suspecting that it could be.
Yeah, and about 400 neonatal diabetes we have picked up, 1,300 MODY we have picked up, 450 congenital hypoglycemia we have picked up, and other genetic syndromes. Some of the genetic syndromes very sad. If you diagnose it, the child will die before 15 years. You can't do anything. There's no treatment even. Very sad, but at least we know. You can tell the parents, according to the podcast, you better look for one more child. There's no treatment today. So not all diabetes is the same. So that is where precision diabetes comes in. Now you may ask, should you do genetic testing for everyone? Not needed. Because as a clinician with 50 years of experience, I can roughly, even when the patient walks in, I can say, oh, this doesn't look like normal. Because some are classical. This is definitely type 2. This is definitely type 1. Small child comes, ketoacidosis, 4 times insulin, 4-year-old, it is only type 1. But below 6 months of age, then it may be neonatal diabetes. After 6 months, neonatal is gone. It's only type 1. So we know. So we tell people, only these people you refer. Only those people. Everyone used to start doing genetic testing, then where will you go? Who is going to pay for it and where is the money? You must know as a clinician who to refer, how to suspect these cases. We will be, after this paper is published, we will be teaching doctors. This is the way you should look for this. These rare things, this is how you should look. Because patients should be treated properly. You should not give some treatment to everybody, give metformin, everyone gives alpha-malaria. Those days are gone. You have to treat in a scientific way.
Since you identified, what is the precision medicine for this?
So, the precision medicine is number 1 to avoid alpha-malaria. Number 2, we treated with other, since we have only 20 cases, it's too small to do a randomized clinical trial. Now we'll tell all other collaborators, maybe if we get 50, 100 cases, we can treat one group in one way, another group in another way, do a randomized clinical trial. This is the first report where we're reporting. We looked at, and not all are our patients, some are treated by somebody else. But we generally found we don't give sulfonylurea and give other drug. See, what is not working in this is the potassium channel. Beta cell is not working, okay? If you give metformin, it works in the liver, it may work. If you give SGLT2 drugs, empagliflozin, all the new drugs, they work through the kidney, they push out the glucose through the urine, that may work. Voglibose, which worked in this case, it prevents absorption of carbohydrate from the stomach, that may work, okay? Any other drug other than the sulfonylurea group of drugs should work.
So direct translation is there.
Yeah, so direct translation to treatment is there, that is precision medicine.
பொதுவாவே டயபெட்டிக்ஸ் பத்தி பேசணும்னா blood pressure பத்தி நம்ம பேச வேண்டியது.
ஆமா.
சோ நார்மலா டயபெட்டிக்ஸ் வரதுனால தான் அந்த blood pressureோட ரேட்டிங் அதிகமா இருக்கா. அந்த நியூ டிஸ்கவர்ல எந்த மாதிரி விஷயங்கள் முன்னெடுக்கும் அத பத்தி ஏதாவது ஃபைண்ட் அவுட்ஸ்?
Blood pressure என்றது, the question is diabetes and blood pressure are connected, so should you connect blood pressure with this? Blood pressure can come in people with diabetes even without any change due to diabetes. That is, blood pressure is also common, diabetes is also common, both occur in older age groups after 50, 60, BP is also very common, diabetes is very common, they can occur together. Cholesterol also, all can occur together. But blood pressure can also come because kidney gets affected. Once diabetes affects the kidney, one of the changes is albumin will start coming in the urine, your creatinine will start going up and your blood pressure will go up. That is secondary blood pressure due to diabetes. It can occur. These are young people, 18, 20, 24. Most of them don't have blood pressure. And they are also thin. They are not the type 2 obese type. So we are not seeing blood pressure as a big problem here. They have diabetes and the diabetes has to be treated properly.
Sir, is there any
Sir,
early
can it be
symptoms for
prevented?
neonatal diabetes?
No, it's a little early days.
Yeah.
It's
Go on. Just introduce yourself.
yeah. Anuradha. So
Anuradha. Yeah, yes, Anuradha. Go on. Yeah.
You know, type 2 diabetes, you have to exercise, physical activity, etc.
Yeah.
But you know, this mutation, which you said of a single gene.
Yeah.
But is there any way to prevent it?
No. So it's very difficult to prevent a genomic type 2 you can prevent. Type 1 you can't prevent, incidentally. Type 2 because of obesity, family history, lack of exercise, stress, all those things you can prevent type 2 diabetes. Here is a genetic defect. So because they have genetic defect, usually it will come. But you can predict who will get it. Now suppose a father and mother, one person has got it. Now they've got 2 children. If we do the genetic test, we can say this child will get, this child will not get. Even when the child is born, we can say who is going to get, who is not going to get. So we can predict. Maybe by not putting on weight and doing exercise, maybe few years we can push it. Instead of getting at 20, they may get at 30 or 40. That we may be able to do. But if it's purely genetic, like monogenic, they will get it. Because it is genetic.
We'll have better treatments.
Correct.
Precise treatments.
And if you control it well, they are fine.
Yes, they are fine. And the ultimate, this thing is only gene therapy for such people.
That is, you have to cure it by doing gene therapy. That is not yet come. It's too, because you may produce a Frankenstein or something if you start interfering with the gene. That will take long time, but it will come ultimately at some time.
Doctor,
Yes.
one question, doctor. The type 1 பேஷண்ட்டுக்கும் டைப் 2 உள்ள பேஷண்ட்டுக்கும் எந்தெந்த உடல் உறுப்புல பாதிக்கும்?
எல்லாமே பாதிக்கும். டைப் 1க்கும் பாதிக்கும், டைப் 2க்கும் பாதிக்கும். கண்ணு, eyes, kidney, heart, feet, nerves, sex organs, all can get affected. Brain, all can get affected. Type 1 and type 2. Type 1, there is a risk of coma, diabetic coma, going into coma, low sugar coma. That normally doesn't occur in type 2 because they've got some insulin, so they'll be able to manage. But otherwise, if you leave them uncontrolled, they will develop all these complications. It is same.
அந்த டைப் 1 ரிஸ்க்குங்களா டைப் 2 ரிஸ்க்குங்களா லைக் ஃபியூச்சர்ல?
Type 1 is much more less common. 2% தான். குழந்தைங்க எல்லாருக்கும் டயபெட்டிஸ் ஒன்றும் வரலையே. Type 2 is increasing very rapidly in our population because of obesity. Okay, even young children are getting type 2 diabetes now. Type 1 is not so common. In the whole country, they say about 8 lakh children only. Whereas we have 101 million type 2. Whereas that is only 8 lakh. But that 8 lakh is very difficult to control. They will take insulin 4 times a day. They will be getting low sugar, high sugar. Now one beautiful pump has come which can control the diabetes fantastically. It's almost like a cure for type 1. 6 lakhs of rupees. If somebody can give 6 lakhs, if government decides to give 6 lakhs to all those children, like in UK they've given every child free insulin, a free pump. So like that, if our government is given, then all the children, Lok Sabha, so many times it has come up. Children should be given free insulin, free pump, free thing. One day it will come. Then children are almost like a cure. If you wear the pump, it takes care. You become normal. Very costly.
Sir, I have a question. Can I have a mic, please?
Yes, sir.
Sir, this is KV Vasudevan from B4U Media.
Yes.
Do you smell any early symptoms in neonatal diabetes? Is it possible with all your experience?
See, it happens too fast. See, it doesn't happen on the day of birth. Okay. So it occurs after 1 month, 2 months, 3 months. If it's on the day of birth, you can do blood sugar for every newborn child and then pick it up. It doesn't occur so fast. It occurs after 2 weeks, 3 weeks, 4 weeks. How can you keep on checking the sugar? And then the incidence of neonatal diabetes is 1 in 4 lakh children. If it is 1 in 100, you can say screen every child. You can't. 1 in 4 lakh children, you have to screen 4 lakh children to get that one child. So screening is not recommended. But symptoms we can tell people. If the child gets some symptom like this, go to the hospital, get blood sugar done. Because once a blood sugar is diagnosed before 6 months, simple genetic test, if they send the sample to us, free of cost we do it, 2 weeks we give the result, child can stop insulin and go to tablets. It's like a cure, almost like a cure. 400, 500 children now all over India benefited from this genetic testing. So, although you may say this is not the commonest form of diabetes, type 2 is the commonest form of diabetes, all correct. What about the children who are diagnosed? For them it makes a big difference. And unless we spread the word through the media that such types of diabetes are there, everybody will be treating the same way only, giving everybody insulin, everybody same way they will be treating. So, doctors and public and everybody, there are different types of diabetes. Just like I said about breast cancer, all breast cancer is not the same. So you must find out which type. So the moment you have breast cancer, you need not be scared. Oh, I'm going to die. No, there are some breast cancer in the next 50 years, nothing will happen to you. There are some breast cancer in 6 months they are dead. Nothing can happen. Whatever treatment you give, 6 months the lady is gone. So knowing that is very important, because the treatment has to be given. Today we have come to a stage wherein type 1 diabetes, in diabetes also we have come to precision diabetes. And we are happy we have taken the lead in that.